Is she going to go to a vet?
Excuse me, it's 5 o'clock. We need to get started. We could introduce the newest trustee here. Cute black lab. Welcome to everybody, including our new service dog puppy, to the Indian River County Hospital District regular monthly meeting. We'll go ahead and get started. And first to give us the invocation is Reverend West. Welcome.
Heavenly Father, this meeting has come to order specifically because this board, as well as those who can hear my voice, love and care about people in Indian River County as much as you do. Lead them and guide them and bless their endeavors tonight as they make decisions to benefit our community. For it is in the name of Christ I pray. Amen.
Amen.
Very nice. Thank you very much. Michael?
I pledge allegiance
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, we will start with the consent agenda. If I could hear a motion for approval of the special meeting minutes dated February 19th, the chairman's meeting minutes dated February 20th, the regular monthly meeting minutes dated February 21st, and the special meeting minutes dated February 27th, and a March disbursement of Mr. Jones.
$1,104,572.98.
Oh, my goodness.
Now, may I hear a motion?
A motion to approve?
Second.
All right, thank you very much. I don't really have anything to go on today. We've got, we had a,
Vote on that? Did we vote?
we,
Motion to approve?
we have a motion to, okay, all in favor?
Aye.
Thank you, Mrs. Crystal.
Sorry.
Mr. Secretary.
Yes, she is. Okay, the district council report, Jennifer is on vacation this week. Her report is in your packet. So we'll go right into the financial review. Mr. Jones.
Okay, thank you. As you might expect, the district continues to be in sound financial shape. And as the financial reports in your packets indicate, at the end of February, the district's bank accounts had about $9.8 million after deducting the $1.1 million we just spent, leaving us with about $8.2 million. I'm sorry, had $9.8 million after deducting that $1.1 million, and we have about $8.2 million in remaining budgeted expenses. So that's going to leave about $1.7 million excess to cover our operations in October and November that are always estimated to be about $1.5 million with no tax revenues coming in. So we always reserve that amount. So I'd say we're pretty close to our plan.
That's good.
A couple things I thought it might be interesting to point out. One, if you look at our balance sheet in those numbers, it shows an entry of a little over $2 million as negative retained earnings. How did that happen? That's because about 3 years ago, we decided not to maintain excess reserves. Excess reserves accumulated over the years when the district actually spent less than was budgeted, and that surplus was placed in a reserve account for unanticipated future expenses. And that's prudent to a point. But after analyzing years of operations, we voted to reduce those reserves on the principle we shouldn't accumulate tax dollars in excess of the annual spending needs. In this way, we've been able to reduce the millage rate from that experience for most of the years prior to 2015, and do that despite the fact we had some pretty expensive one-time expenses, particularly related to the new hospital transaction. Another point ought to be made, too, that relative to the district's taxes for healthcare services. In the most recent calculation we did, which was in fiscal 2017 and 18, the district represents about 5.7% of your total property tax bill. In short, if the district taxation went away, most of you wouldn't notice much. However, much of the population that's served by the district support would notice pretty quickly. For example, 2/3 of the births in our county are supported with prenatal care funded entirely by the district. Similarly, we provide about 1/4 of the health department's annual budget, plus support for the VNA, Healthy Start, Treasure Coast, Mental Health Association, and many others. And they wouldn't be able to function at the levels they function without this support. So I think we should be proud of the balance being achieved between minimizing the taxpayers' exposure and burdens and still providing the vital healthcare services to a population that really needs it. That concludes my report.
Thank you. I think it's important that everybody understand that we are all very aware of our fiscal responsibility as well as taking care of the community. So I think this board has done a very good job in terms of that. Anne Marie Suriano, our executive director, is also on vacation this week at a spring break, but her report is also in the packet. So we'll move on to the funded agencies quarterly report, and we will start with Dr. Creelman.
Good afternoon, honorable commissioners. Nice to be here. You have before you in your packet the University of Florida Department of Psychiatry March 2019 first quarter report. And as you see on page 2 in your report, our visits for the quarter were 61 psychiatry visits and 89 addiction medicine visits for a total of 150 visits for that particular quarter, which is just a smidgen up. If you look at last year's data, we had a total of 466 total visits for our last fiscal year, so running just a little bit higher at this juncture. Obviously, addiction a little bit higher than psychiatry with the Suboxone program that we have. And that carries over to page 3, where the medication voucher expenses for our center were $7,270. And I just wanted to, Commissioner Weiss is always asking me about, how much these things cost. So specifically for him, there are several doses of Suboxone, but essentially there's a 8 milligram film and there's an 8 milligram tablet. Then there's Subutex that does not have the naloxone, which also has an 8 milligram tablet and a 2 milligram tablet. The nicest thing to use is the film, because you can cut the film literally into eighths as you decrease and taper the medication. Unfortunately, the tablet sort of begins to disintegrate if you try to really quarter it. And we're always trying to get folks from the Suboxone to the Subutex because it's much cheaper. A 8 milligram Subutex tablet is $5 versus an $11 for the Suboxone film. So we always try to get people down. The problem is in those individuals that will crush the tablets and then inject it intravenously. We don't want to give them the Subutex, because if we don't give them the Suboxone that has the naloxone, it'll block any other opiate that they also might be injecting. So the point of this complicated biochemistry is that we're always trying to use the least expensive medication to sustain the recovery period of the folks in the Indian district that we care for in lieu of them going to jail or buying the stuff on the street. On page 4, just to give you a little follow-up on our activities, we've been working very closely with the Connection Center, the McCabe Connection Center. I think we're one of the major providers of psychiatric evaluations. First year, I think we'd done over 250 psych evals. We're continuing to collaborate with Suncoast Mental Health. Dr. Koo works there 1 day a week, both in their Fort Pierce location and the Vero Beach location. And then we've recently contracted with the Children's Home Society, where Dr. Koo provides telepsychiatry half a day, twice per month. So we're very busy, still have a nice waiting list. We feel somewhat optimistic. As you see in your financial material, there's still a vestige of the bridge funding that you were kind enough to give us the past year. We're in good shape for this current fiscal year ending June 30th. We're in pretty good shape for the next fiscal year. And Debbie Mayfield and Aaron Regualr have really taken the bull by the horns. And I just found out today that there's part of the spending bill in the Senate. Didn't make it through the House subcommittees, but it did make it through the Senate for an additional $100,000 for the next 4 years. So that's going to be in the senatorial budget. Then that'll get, of course, debated back and forth. We're also meeting. We've got a great group, an advisory group, to look at long-term funding, both from the point of view of operations as well as endowment. And just parenthetically, I had a very nice meeting with Dr. Gregory Rosenkrantz, a new CEO over at the Cleveland Clinic, Indian River Medical Center. And I think he's very happy that we've got the same exact model in our teeny little building that they have in their huge event out in Cleveland and also down at Weston. So we'll be talking further about collaboration. We would be talking earlier, but Gina Palladino, our manager, gave birth prematurely to little Ellie Palladino at 26 weeks, and so this is incubator sort of time. And so when she gets back to work, we'll do some joint visiting back and forth between the BHC and us and see how we can have a greater collaboration with the Cleveland Clinic.
Are baby and mother doing okay?
Yeah, they are. Yeah, I last heard 1 pound 14 ounces. Yeah. So, any questions? That concludes my my report.
Thank you.
Thank you very much for an excellent report, and I'm glad to see you balance the patient's needs with their economics. Very nice, and I appreciate it.
Thank you, Commissioner.
I'm glad to see that your financials are getting more stable.
Looking better and better.
Good. That's good. Thank you very much.
Thank you.
You bet.
Okay, next we have the Public Guardianship Program. Morgan?
Good evening, everybody. How are you?
Hello. Good.
Thank you for allowing my service dog in training to attend. It's very important that they get out. I apologize that I did not get my presentation over in time to Kate, so I will be presenting. A lot of this will be familiar for you all. As you know, our board is consistent and has remained the same with Mr. Swan as our president, Lisa Barnes as our treasurer, Margaret Libby as our secretary, Lisa Kale, and Anne Marie Soriano. As of March 21st, we have 16 active cases, which is an increase over our last report. In the third quarter of our fiscal year, we do have a waiting list consisting of 4 individuals. And many of our clients during the past quarter have received medical care in the community. While most of our clients are found in facilities and receive their care there, we do have several that are living in group homes or assisted living facilities, so they do require care at external facilities, which we collaborate with places like Treasure Coast Community Health, the UF Psychiatry Clinic, those places. So of our 16...
What happens with
sorry?
these 4 that are part of your waiting list? What
I'm doing everything I can to reach out to our other agencies that may be surrounding us, like St. Lucie or Brevard, to see if they can absorb some of that if they have openings. A lot of times I'm offering support services during those times to the individuals that are involved with those people to ensure that they have appropriate services in place. Maybe there's something else that can be done within the community in the meantime to bridge that gap. So we do everything we can to kind of keep things afloat for them.
you just don't have the manpower to deal with them?
I don't
right?
at this time, yeah. So the 16 active cases, we had 7 seen within physicians in our community. Those 7 clients had 18 total appointments between them. And of course, we implement their care plans at 100% success rate. We did have 2 clients that were hospitalized. One ward passed away, and one did have a fall and required surgery, but we were able to implement a therapy plan for them to return to their facility. Because we did have one ward pass away, it may be possible once we are discharged as guardian, because there's still a lot of documentation and things that need to be completed prior to discharge, that we could accept another case. So, our agency had participated in a cost per ward study with the Department of Elder Affairs this year, and part of that was because we recognized that this hadn't been done in quite some time amongst all the programs, and therefore what was being recommended for the governor's budget was significantly less than what it should have been. So the chair for the Healthcare Appropriations Subcommittee released her budget proposal, and the chair has recommended a $2.4 million recurring funding for the public guardianship program. That is an increase for us. That amount is also the exact amount that the governor requested in his budget and recommendations. So we feel very confident. This will allow about a $430 cost per ward increase. It doesn't necessarily mean that all programs will be able to provide more services, but it does mean that maybe services could be more comprehensive. Our programs could be made whole with this funding. I have some very exciting news. Part of our program search and growing up has been, how do we better collaborate with this community to make sure that we are meeting the needs of this community by reaching all potential clients? Late last year and early this year, efforts began with the Senior Resource Association, and in January they did decide to acquire our program, which is a tremendous opportunity for us because it means that more clients could be served as they have more caseworkers and more manpower to make that happen. Johns Island Community Service League voiced that they were very encouraged with this and felt like that was a good representation of what communities can do in collaboration with one another. So we are very excited that they will be acquiring us. June 30th, 2019 will be our last day as the public guardianship program, and July 1st will be the immediate takeover. We are planning that in accordance with our fiscal year and along with our contracts with the state of Florida. So I do want to say a special thank you to to the hospital district and to my board of directors, because without them we couldn't do what we do, and it really means a lot.
So public guardianship goes away, or it just becomes a subset?
It's going to be a subset of the
subset.
Will any one of you be following, working with Karen over there?
We are going to make sure that they have a mentoring program during the next few months to ensure a smooth transition. I will not be continuing.
I didn't think they had the room over there. I was there last week to deliver Meals on Wheels as a volunteer.
They will be adding a position for this executive director. So.
Will they be able to, since it's being acquired by the Senior Resource Association, will they be able to come before us and ask for funding for this specific program for the upcoming budget season?
Yeah, I mean, I don't know. I think that will have to be something that obviously would be taken into consideration given Karen's position. But we will work diligently during this transition to participate in that application process since we know the needs. It is not my intention to hand the program over without a smooth transition.
What are you going to do?
I have accepted a position at St. Edward's School, so I will be transitioning.
Is she happy?
Is that a happy call?
It's been a very
Mixed emotions here?
Very bittersweet. I'm very excited for this program. It's been a lot of work. I have worked unpaid for many years.
Tirelessly.
Yeah.
Tirelessly.
So, but it really means so much to me that this community supports this organization, because I can tell you the need is great. And I've seen a lot of people through the transition of dying, and that's been very hard. you know, in my short time as a guardian, I've lost many clients, and that's not easy being the only person when they have no family or friends saying goodbye. So it's, this program's been an incredible gift. I've learned so much. And it's one of those things that is, was very hard decision for me not to continue on with it. I was offered that position, and I think that I would not have turned it down if I didn't feel confident that this would be taken care of properly. And I feel very confident in the training that SRA and the commitment that they are putting forth. I intend to fully see this transition through to even help with the hiring decision of the new director. And I have been coordinating efforts with the Department of Elder Affairs to ensure that they are aware of this and fostering our program through this transition as well.
This was a decision of the board
To
move
be acquired, yes.
SRA?
We had some conversations about a year ago where we really took a hard look at our budget. And of course, without this help, we couldn't even serve 16 clients. So that's a huge feat for us. But it's the fact that we can't grow up where we need to be without collaborative efforts. It's not necessarily, it's not just lack of funding, it's also lack of manpower. It's very hard to train people to take on this role. It's hard to convince people to take on a guardianship role. It's a very labor-intensive job. It's 24/7 on call, so.
Well, your mentoring is going to be very important to SRA.
And our board knows the importance of that between from Mr. Swan all the way to
Right.
Lisa Kale. They all feel strongly as they were founding members of this organization, so it's near and dear to their hearts too.
You should be very proud
Yeah.
of what
You
you
should
have
be very proud.
accomplished and what you have done. And for those that you have taken care of,
Thank you.
they were very fortunate to have had you.
Thank you.
And I
I'm
love,
gonna get emotional.
I love the speaking to of the collaborative effort, because I think that's kind of been the theme as of recent, of really getting people involved in the community to partner together to serve our community most effectively. So I applaud you for seeing that early.
Thank you, yeah.
And we'll continue to support the effort.
We appreciate it. And I think somebody asked me at Johns Island when we were doing a speaking engagement how many unserved clients there are, and my best guess is that there's probably 3 times the amount of people we're currently serving that need our services. So I know that this is the right transition, the right direction for the program. It will allow those people to be served. It will also fit within the continuum of care. You know, it's a very natural transition. It's a very positive one. I'm very proud of the fact that we have very supportive people in this community and also a great board that wanted to see this through. So I appreciate everybody. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.
Wow. Okay, we're going to go into unfinished business now. So now we have the VNA. Thank you very much, Morgan, and good luck to you and your puppy.
Good evening, everyone. Thank you very much for allowing us to talk with you a little bit further this evening, and thank you for yesterday allowing us the time to present to you what we've done with the Vulnerable Village Community Education Initiative over the past 6 months. We'd very much like to be able to continue our work that you so generously supported, and not just with finances, but with your input and your feedback and working with us as collaborators in our large community collaborative as well as individually, which we've greatly appreciated. I can't tell you how much we appreciated that, really. I just put a brief summary together, a very brief summary together of yesterday's discussion, which incorporated, promise there's not 36 slides, which incorporated some of your excellent feedback. So just want to review that very briefly. In the next 6 months, we really want to focus on bridging resources in the right way at the right time, building upon what we've learned with the understanding that we need to expand our presence in these vulnerable areas, because what we learned is being there doesn't equal trust in and of itself. It's a time effort that takes time to build relationships with patients, with people, with community leaders. So we want to continue to do that work. We want to focus on educating, continuing to educate on the financial assistance program and expanding a plan for qualification and follow-up with patients. That's something we want to commit to. We've laid a really good foundation, I think, for going forward, and now I believe we'll have a little bit more time to focus on some of these other things that we really wanted to do, especially relative to follow-up. We're going to increase our emphasis on connecting patients to primary care, whether that be an individual physician or a clinic. We want to make sure that patients are aware of programs like the 340B discount, drug discount program, and other free prescription resources throughout the county. There are lab, physician, staff. There's a lot of things that we can really be doing to educate patients to other sources, resources that are available to them. So we want to increase that effort. And we want to deepen those relationships amongst community collaborators through the business associate agreements and being able to excuse me, have a team-based approach to that continuum of care. So sharing with other community providers the names of people through these business agreements that tell us they're patients of theirs. We want to be able to connect the dots, if you will, Mary Beth, and understand why patients are coming to us and not those providers if they are patients of those providers. And conversely, if they're not patients of those providers, being able to connect them to those providers so that they can get the long-term care that they need. Many of these patients have chronic conditions and they have a need for long-term management. So we want to make sure we're deepening that and reporting on the number of patients that we connect to primary care. We also want to continue to support the need for same-day urgent care in Indian River County. There is a need for that. Right now, it's really the emergency room and us. We do have some other initiatives that will be evolving this year. The Lawnwood Emergency Room is coming into the county at the end of Q3, I suppose, or maybe the beginning of Q1. Q4 rather, in 2019, and then we also have some other same-day potential.
I think the United.
The United Up is putting,
Up
yes,
is putting
with TCCH, there'll be a platform there. So that's actually good for all of us because there'll be an opportunity to really address the needs of many, many patients, not just the ones that come to the mobile clinic. We want to broaden the exposure to the Positive Change Program. One of those action items, of course, would be to complete the 30-day enrollment. We have 6 more patients to enroll, but we're not going to stop at the 6 patients. We're going to continue to enroll with the understanding that there are people that won't come back for follow-up, and we want to try to see as many patients in follow-up as possible. So we'd like to have 90-day data on all patients who do return for follow-up by the end of the year for presentation. When I say year, it's the end of this year. However, clearly by the end of September, when if we do get the support from you again to continue our work, at the end of the next 6 months, of course, we would give you where we are, what our status is with the Positive Change Program. And importantly, based on feedback we've gotten from other providers and from some of you in our collaboration, we'd like to extend the Positive Change Program to other organizations in the community, such as United Against Poverty, such as Samaritan Center, other places that have patients that maybe could benefit from this program, making lifestyle changes and being followed by a healthcare professional. So we'd like to be able to do that as well.
You had any contact with like Hope for Families or Camp Haven or any of that?
We have not.
Okay.
No, but those are great suggestions and people we can certainly invite to join the collaborative for the next 6 months.
Okay.
Get them involved. Thank you for that, Mary Beth. We want to increase our efforts around education and prevention at community events. We talked a little bit about that yesterday, being available within the community to have a better understanding of all the communities, not just where the bus is located in those 6 communities, but other areas to gain a better understanding of where people might need help and where we can provide education on community wellness and where we can do blood pressure screenings and blood sugar screenings. So we want to increase that effort. And then reporting to the district, community collaborators, and incorporating feedback to modify our surveys to gather information that's necessary to inform decision-making, not just for decisions that we want to make, but decisions that really affect the entire collaboration to best serve the patients that all of us have access to. So that's a summary, really, of what we talked about yesterday, and I want to take a stop for a moment and ask if any of you have any questions before I start talking about the budget. No questions? Okay. So, as I started saying, we'd very much like to be able to continue our work with the Vulnerable Village Education Initiative. We saw this as a year-long program when we first came to you a year ago, and we had agreed, because it was something a little bit new with some new areas of focus, that we would look at it at a 6-month intervals, see how we did, and come back to you and kind of report where we are, and then talk about what the next 6 months would look like. So we're actually asking for the same amount of money that we asked for in the first 6 months. We need that money to cover our staffing, to cover the needs associated with the program, Positive Change program, that's materials and so forth, and really the operation of the mobile clinic. And so we're asking for $150,000 again. The cost actually for 6 months has been estimated at $153,880. And we do have the full budget. Tracy did ask about having the full budget, what it costs us to run the mobile clinic for a year, and I wanted to provide you with that number as well, which is $412,167.04. The VNA's contribution to this initiative is $101,000. I'm sorry, I can't say the number. $12,000. That's our contribution, approximately $50,000 each 6-month period. So we'd like to have that same amount of money, which has been a very generous support for us, something we really feel very passionate about, something we feel that, you know, we've raised the quality, and we want to continue to keep that quality at the high quality that it is now, and continue to raise the bar as we work with more and more community providers and community collaborators, so that we can really try to make a difference in the lives of these people that we're serving, who are indigent, have no other access. But through the VNA mobile clinic, hopefully we're driving access and in working with other collaborators and clinical providers, so that these people can have long-term care, which is all of our
You guys in 6 months have done a phenomenal job. With the amount of resources that you have, and creating the relationships and communicating with the different, you know, communities. And so I love that you've made a huge effort to collaborate with the other agencies in our community, because I think that was lacking. So I love that you've kind of mediated that as well. So I'm excited to see the next 6 months.
Thank you for that, Tracy.
Yes, I'd like to know, do you have an idea of what it costs per patient visit for you?
Yes, so per patient, it's approximately $130 per patient. If we actually take the number of patients we saw and divide it into the budget, we have a fixed cost of $110, which prior to my actually doing this initiative with Lundy, we had a fixed cost at the VNA, which was estimated at about $110 per patient if we actually were to charge them.
Do you have any other thoughts, Michael? Comments?
No.
Barbara?
Did you receive any co-pays from the patients?
So yes, we do charge the patients. We don't consider it a copay because they don't have any insurance, but we charge them $5 for a sick visit and $25 for a physical, whether that is a school, sports, or pre-employment or work physical. It's $25.
Mm-hmm.
And we have found the majority of patients in the last 6 months, actually in the last 5 months, because the first month we were still doing quite a few where we were waiving the fee, but we have found that the majority of patients actually pay, and they don't seem to mind paying. So we're happy about that. We feel like they have some skin in the game, and that's something that our advocates had actually stressed for us. The patients must have, you know, some skin in the game and must have some buy-in. So we listened to our advocates, and they were right. And so, you know, we found that to be something that people feel a sense of pride, perhaps, that they're able to pay something for their care.
Where do they go? I'm sorry, Bob.
I just was wondering that your 6 additional patients,
you had those originally, and then you had some that came out of the program?
So the way it worked is we had quite a number of patients that were interested. Then we had quite a number of patients who scheduled visits for an initial visit. Of those people that scheduled a visit, which was probably close to 40, we've had 24 patients actually show up and enroll, if you will. We have another 5 patients who are scheduled for their initial visit, so we're hoping that at least 2 to 3 of them will show up. And then we continue to recruit. We continue to have people complete the health screening tool because we want to continue to accumulate that data as well. And so that's how it works. So we're continuing to recruit, and as I said, we will continue even when we get the 30 patients. We won't stop. We'll continue collecting the health screening data because we have found that to be important for our decision making, and we also have found that our collaborators really like to have that information and see that information, so we'll continue to do that as well.
Thank you.
Pat, I think you said something about following up if they don't show up. So there are phone calls made and
Yes.
and people, does anyone go out to the home at all?
So we haven't done that, Anne Marie. We have made at least 3 to 4 calls documenting 3 to 4 follow-up calls. We've not gone to their home. I mean, it's possible it's something we could consider in the future. I think at this point, perhaps because it's a volunteer program,
Right.
we felt maybe that might be intrusive and maybe something that if they're not responding to us by phone, they might not appreciate. It's been mentioned, and certainly something we could consider for the future in select cases.
And where do you send these people if you detect that they need labs?
So if they need labs, we let them know about physician stat. We let them know about the financial assistance program first and foremost, that if they have the financial assistance program, they can go to other providers that are funded by the district, and they're able to get either very low cost or no cost services depending on, the sliding fee scale and so forth. So that's the first thing that we tell the patients. The second thing would be to tell them about physician stat, where they can go, I think it's on Wednesday, and they can get certain tests, for $10 for a copay. And, we tell them about other resources. We give out the McCabe Connection Center card. We now have United Against Poverty cards and flyers on the bus. So TCCH is creating a flyer for us to give out to patients, so patients have just a little snapshot of what these other providers can offer to them. And we talk about it as well.
I would think the lab piece would be very important for any kind of a program, because you can't go to the doctor without first having to do a lab.
It is, you're right. I mean, we do random blood sugars, and we've picked up a few elevated blood sugars,
Right.
even on people that have come to us not.
Oh, so you can do some preliminary.
We do some preliminary, and even if they come to us and they tell us, well, we haven't eaten breakfast, we consider that a fasting blood sugar. And we've picked up a few, where people were at, a fairly high rate, and then we refer them. Again, in the Positive Change program, we know we're going to see them again, so we will ask them about that, or we hope we're going to see them again, so we will ask them about that. But we don't always know, what happens to the people, but we're going to make a much bigger effort now that we've laid the foundation for everything to do that over the next 6 months.
Weren't you applying for credentials to be able to accept reimbursement from insurance companies and Medicare and Medicaid? Where do you stand on that?
So prior to my coming on board at the VNA, there was discussion about the possibility. I don't know, Lindy, can you maybe put a little bit more light on that? I don't have a lot of background on that. I do know that there was discussion about that, about the potential to have the ability to accept insurances on the bus. But over time, I think that went away because really the people that we're seeing don't have insurance. The majority of the people that we're treating are people without insurance. So if we were to accept insurance, which is a very time-consuming, resource necessary activity, we wouldn't really be seeing patients that have insurance. So I believe the decision was made, to not pursue that.
So you did say yesterday, though, if I remember my numbers correctly,
Yep.
there were 78
70,
patients or
70, yeah.
77,
Yep.
right?
73.
Patients that had insurance.
Yeah, and they do, and we do ask them that. Now, we don't accept their insurance, but they come to us, and we ask them why they came to us, and those are the patients. You know, we do have the ability to bill Medicaid for some APRN activities, but it's very, very rare that Medicaid actually reimburses those activities, and as Medicaid transitions to managed care Medicaid, we don't have the ability to bill the managed care Medicaids, only government-issued Medicaid, and really that's transitioning out. So that's
Managed care that didn't
managed care
come through.
Medicaid, yes, exactly. So that's really where we are now. Yeah.
So I have a question. Do we have the money?
Yes.
So can I hear a motion from,
I'll move that we provide another 6 months' worth of funding as requested by the VNA mobile unit.
I hear a second?
Second.
Any other discussion? All in favor?
Aye.
Aye.
Any against?
Very nice presentation, Pat,
Thank you very much.
and yesterday's
Thank you.
as
You've
well.
done
Thank you for
you've
what
done
you're
a
doing.
great job with this.
Thank
And
you.
get that connection now. Get them to their home.
Highest on my
And
list. of
keep up the
priorities.
collaborative effort. I think Tracy said it very eloquently. That collaborative effort has really made a difference, I think, with all of the agencies.
Thank you all. Your commitment is just astonishing to me, and I'm just really, really thrilled and excited to be part of this. And it's a bit of an emotional evening following that other
You're not going to cry, are you?
presentation. But
You're not going to
But,
cry.
we are extremely grateful, and I know I speak for everyone at the VNA when we say how much we appreciate everyone's support that we've had over the past 6 months, and we look forward to working with you again over the next 6 months and beyond.
And I have to say that I appreciate the data. Okay, I am that data nerd as well too. But what sells me is the data and the information on what you've got. So
That's good on
And that
data.
you make it so transparent.
love data.
Anytime anybody asks a question, like, you're immediately able to back it up with numbers and data, and I agree, that's very important.
Well, thank you all for that. It's a large collaborative effort, and I really want to, give the credit to the nurses on the bus. It's not an easy job to sit on the mobile unit and see patients in the way that they do, and they're just incredible, dedicated, amazing people, and I'm honored to work with them, and the clerks as well. They're just truly amazing, gifted individuals who truly care about serving people, so I just want to say that. So, thank you all so much.
crying here soon if we don't.
Thank you.
Next time, we're going to
Thank
put
you so
tissues
much.
Very
at
much.
the water.
All right, as far as new business, we have action required in your packets. We have, it's not as formal as what Jennifer would write up with all the whereases and wherefores and all that. But if I can just read through this very quickly, and then we'll vote. On this day of March 21st, 2019, the Board of Trustees approves the following changes to the Financial Assistance Program. In terms of identification, the applicant must provide one photo ID or one form of acceptable identification. A list of acceptable documentation can be found in the Policy and Procedure Manual determination for eligibility criteria. In terms of residency, an applicant must be an Indian River County resident. Proof of residency is satisfied by providing 2 current documents in applicant's name that confirm address on the application or is an address in Indian River County. Income. The annual household income must be less than 200% of the federal poverty level guideline. Gross income is the amount of income received as of the date of the application for the time period of 4 weeks prior. Income, if income is self-declared and is less than $900 per month, a letter of financial support is required. Insurance. The District Healthcare Financial Assistance Program is available for applicants whose insurance benefits has exhausted and is seeking service for a medically necessary condition. Applicants who are otherwise eligible for Medicaid must first comply with Medicaid and include a reason for their denial. If denied due to noncompliance, applicant is not eligible for financial assistance. A copy of the denial letter must be included with the application. These changes will begin with the 2019-2020 financial year effective October 1st, 2019. May I hear a motion for approval?
I'll make a motion to approve.
Okay, may I hear a second?
Can we still,
We
like?
can talk,
discuss?
but we
Okay.
can talk then.
Second. Did
Okay.
somebody second it?
No.
No.
Are you seconding? Okay, now, discussion?
Did you want to?
You go.
I had, in going back through all the information that we kind of talked about yesterday, I just have a concern that we don't really know what this is going to cost us if we go up to 200%. And we mentioned before, you know, people may drop their insurance in favor of us or the hospital district funding their health care instead of sticking with Obamacare or the insurance that they have. I think we all want to help the Alice population and see that they get the quality health care that they so need and deserve. I'm just concerned we don't know what this is going, this could potentially cost the taxpayers a lot of money. And is there a different way that we could do it by, when Alan mentioned doing program grants and things like that, we do, I don't know if subsidize is the right word, we do that for the Partners Program. Is there another way that we could participate without like doing this unknown cost to the taxpayers? I'm just concerned that they're gonna
I
drop.
understand. I guess a couple things I would respond to that, and anybody else can too, is that if we do this, we will know what everybody's going to come and request in their budgets.
Okay,
So that will tell us, okay? If in fact who they serve goes over that, we have the ability, I mean, it is our choice to be able to approve anything over what is budgeted.
Okay.
So if we approve this tonight, the budgets for this fiscal year from the agencies would be at that level. So we will have an idea of what the financials are. And then we have a right to be able to approve or disapprove what that is.
well,
I'm
I'm
correct at that, right?
will we be able to know whether, does this cover like wellness checks and primary care and those kinds of things? Or is this gonna cover like heavy-duty medical and, you know, catastrophic medical as well?
Hospital is not included.
Right.
Okay, so
So it is the primary care support.
if it comes out that this is going to be an excessive amount or an excessive burden financially for the taxpayers of Indian River County, can we relook and reevaluate it the following year before budget? Or is this set in stone?
You can always
No, we can
reevaluate.
always,
Always evaluate it, and we don't have to, if all the budgets come back and it's, you know, $18 million or $20 million, we always have the right to be able to say we can't do that.
Okay.
That, I mean, at budget time, that's our,
Well, the budget goes from year to year.
right.
And what you read, the paper that I have, I don't see where you have any increase. You didn't mention.
These are the changes, so it
Those
goes
are the
to
changes from
200%,
yesterday.
from 150 to
Where is
200.
that? Doesn't
Right
say
here.
it.
It goes to 200%.
I'm sorry, you're right. Okay, income.
Yeah,
That's-
under
okay.
income.
I want to help the Alice population. I think it is part of our duty to do that. I just want to make sure that we are making the right fiscal decision in doing this.
I understand, you want to be prudent in spending the taxpayer's dollar.
And I want people to keep their insurance. I don't want them to drop their insurance because they, know that they can now come to the hospital district for,
but again, I think a lot of their insurances are more the catastrophic
okay.
type insurances
do
versus
have a
what
state.
you or
Okay.
I.
Most of their insurances are going to pay for routine visits.
Okay, Mrs. McChrystal.
Okay.
No, I'm done. I just, those were
I'm
my
the yang.
concerns.
Okay.
She's the yang, I'm the yang. Okay, and I've
Yes,
typed mine
Mrs.
up.
McChrystal.
Thank you. Historically, for the past 20 years or more, The district has provided indigent health care funding for those whose gross income is less than 150% of the federal poverty guideline. During that time, we have witnessed a dramatic increase in the cost of health care for our citizens. United Way CEO Michael Kent reported to us yesterday at the chairman's meeting that 51% of Indian River County families struggle to meet basic needs, and health care is one of the most basic of those needs. I am of the opinion that an increase to 200% rather than 250% of the poverty level is no more than a baby step toward addressing the health care needs of our most vulnerable citizens in the community. However, in lieu of the fact that the majority of trustees favor an increase of only 200%, and more than one seems to be focused on not increasing the taxable millage rate past 1 out of an allowable 5 mills assigned to this most critical of needs, my vote will be a yes to this motion, with the hope that this matter can be addressed once again in the not-too-distant future rather than be delayed relative to the Cleveland Clinic obligation. That's my statement.
Thank you for your statement.
We've gotten some information yesterday, and some of the items, if we read carefully, the state inflation costs have gone up, I think it was 9% over a 3-year period. Nationwide and statewide, Indian River County was 15%. So we have seen almost twice the national average increase in costs to people in the community to live, and yet there's no salary increases that come close to that. So working people in this county have been losing ground economically over the past 3 or 4 years, rather than gaining ground or staying level. So going from 150 to 200, you're just about keeping up with the loss of income over that time frame. And I thought that should have been emphasized more yesterday when we had that information given to us, that working people really are losing money rather than getting salary increases over the past 4 to 5 years, double the state average, double the national average. Which there was no explanation for why that was happening, but I think it's something we have to consider.
It's a good point, Michael.
Yeah, I'd like to make a couple comments. I guess I'm going to support this as it's written, though. And the reason is because I think this is a step in the right direction, but I don't think it's the way we should be doing it going forward. But Mary Beth referred to it as a baby step, so maybe that's what it'll be. I hope that's right. My concern is that Tracy will be right, that we're going to have more expenses than we anticipate. So therefore, I would have preferred that we do this associated with a grant method of reimbursing and supporting these agencies, as opposed to the fee-for-service methodology that we've used as an extension of what we did for years with the hospital. Because I thought it was easier to cap. Mary Beth, though, is correct. We can budget whatever we want to budget. And if the funding that comes through the fee-for-service proves to be inadequate for these agencies that provide the health care service, we can say we're not going to give you any more money. So we reserve that right. We reserve that right with the hospital. What I do like about this is that it is close, the 200% is more closely aligned with what the other agencies do. What I don't like about this is that we're still requiring the agencies that actually provide the work to provide a little extra administrative support to do things a little differently in order to earn the taxpayers' money. Personally, I would rather just support the agencies that do this work and let them do it their way, and then they have to convince us that they're supporting the population that we want to be served. And I think that would be a lot easier for everybody, not only for the agencies that actually do the work and have to apply for reimbursement, but I think it'd be easier for the district as well, who's now had to hire one full-time employee and one part-time employee just to keep track of this. But like I said, this is directionally correct. So in the sense that this is a baby step toward where I think we'll end up in the future, I'm going to support this because I think it is better aligned. And then secondly, I think it's worth mentioning the millage rate because we talk about the finances. And I don't know what we're going to do. We haven't made this decision, but I can tell you where I sit today waiting to hear more debate on this. And that is as the hospital removes itself from us requiring, from needing our support to provide indigent care. And that happens over the next 29 months. As that happens, the taxpayer is going to, or we will see less money being committed for this area. And we have yet to reconcile what we're going to do with that money. Are we going to return it all to the taxpayer? My view is more Solomon-esque, I guess. I think we should have a general plan that as we accrue these savings, half of it goes back to the taxpayer in terms of millage relief, and the other half goes to the agencies because no matter what we give them, they won't have enough to pay for the care that they're providing to this needy population. So I think we can do both. And so when we get to the budgeting process, at least that's the way I'm going to look at it as we propose it. And so I'm going to support it because I think we're going in the right direction. We're more aligned with the agencies, but I don't know why we just don't let them do it. And because they do yeoman's work, whether it's Treasure Coast or Whole Family Health or VNA or the Partners Program, and you could just go on and on about the resources in this county that really need this support to help people that are in great need. But one step at a time. So those are my current thoughts.
Alan,
I reserve the
you were
right to
very
change my
eloquent
mind.
and said better than I did, because I agree with you and everything that you said tonight. So, thank you.
I personally am looking forward to, we spent a lot of time going through a strategic plan, and a lot of the strategic plan is learning about population health, learning about the county, and learning about healthcare regulations coming down and all of that. And I think the more educated that we are and the more knowledgeable that we are about the county, the situation in the county, who's supporting it, and where healthcare is going, we'll make more educated decisions on what we do with the money and how we go about doing it. So
Nobody can dispute that.
so I think
I actually have a
changing right now-
suggestion for you then.
I think changing right now is premature. So,
I think when our lease expires, we move into the Gifford Health Center.
okay, so we.
And
will-
then
we
we'll
can
really
have-
learn about the population and save rent in the process.
I am
So
not
we have
we'll
a-
see how
we
that
have- We have a
evolves.
large county, it's not just in that
Alan,
location.
I just
so.
wanted to point something out to you. When you're talking about the mill rate, as we progress year to year, we're going to see the value of the assessed value of the county go up. Usually about 3 to 4% a year. So that's means that if we just left everything alone, our mill rate would be decreasing based on the fact that our income is the mill rate times the assessed value. So it's, a balancing act.
I agree.
So back to
The vote.
the proposal for tonight. Okay, we had a motion and we had a second, so all in favor of this as it's written?
As
Aye.
it's written as a baby step, aye.
Aye. Okay, any nays? Okay, thank you, we did pass this, and we will move forward. And so now we can instruct the agencies to put these changes in so that their budget requests reflect these changes, okay?
Will that go out then tomorrow to the agencies? Yeah.
I think that's very important. Is there any other business?
See, the VNA left without hearing this wonderful.
Any
I'm
other
sure you'll
business?
contact them.
Any public comment? Okay, this meeting is adjourned. Look at that, right before 6 o'clock.